Imagine having an organ the size of a bowling ball removed from your body, and you're sleeping in your own bed by dinner time that exact same day.
Yeah, I mean, that is not a pitch for a science fiction movie. It is the documented reality of modern women's healthcare technology right now.
Right, which is incredible. But then on the flip side, in that very sane field of medicine, you have patients walking into high-end luxury med spas for, well, unapproved cosmetic laser treatments, and they're walking out with permanent severe injuries.
Exactly. We are currently living through this massive transitional phase. The industry is just moving so rapidly away from highly invasive, prolonged procedures toward same-day, highly personalized treatments.
But, you know, that explosive innovation brings incredibly complex safety challenges.
Oh, absolutely.
So welcome to the deep dive. Our mission for you today is to cut through the noise of modern women's health tech.
We've pulled together a really fascinating stack of sources for this one.
Yeah, ranging from strict FDA safety warnings and slick commercial marketing materials, all the way to the absolute bleeding-edge research from the 2026 European Society for Gynecological Endoscopy Congress.
Right, and some groundbreaking new legislation out of the UK, too. We really want to help you separate the genuine medical breakthroughs from the shiny marketing hype.
Because the gap between those two things is exactly where your safety as a patient is either fiercely protected or dangerously compromised.
It really is.
I want to start at the most commercialized and honestly the most controversial end of the spectrum. We are talking about treatments that are aggressively marketed directly to you, the consumer.
Right, the stuff you see scrolling on your phone.
Exactly. If you spend any time online, you've probably seen ads for energy-based devices, so things using lasers or radio frequency, and they're promising, quote-unquote, vaginal rejuvenation.
Yeah, they claim to treat laxity, pain, dryness, I mean, you name it.
But this is exactly where the medical frontier starts to look really chaotic. There is a stark disconnect between what those glossy marketing brochures promise and what regulatory bodies are actually warning us about.
A huge disconnect. Both the US FDA and MedSafe New Zealand have issued very clear safety communications about this.
Yeah, they state unequivocally that the safety and effectiveness of these energy-based devices for vaginal rejuvenation have not been established at all.
They just aren't approved for those specific issues. They are not cleared to treat menopause symptoms, urinary incontinence, or sexual function. Full stop.
Right, and to put some hard data to that, there was a cross-sectional analysis of the FDA's M-NOD-E database.
Just for context, that's the registry where adverse device events are reported.
Yes, exactly. So Dr. Ghislaine Alawalia conducted this analysis, and she identified 45 distinct adverse events involving these specific devices.
And we aren't just talking about mild temporary discomfort here.
No, not at all. The reports detailed severe complications where patients actually had to seek ongoing medical care for long-term pain, severe burns, numbness, scarring, and even physical disfigurement.
It's terrifying, honestly.
It is. So, question for you. If the FDA hasn't approved these lasers for these specific issues, how on earth are they being marketed everywhere?
I mean, to me, it seems like an incredible failure of the regulatory net. Like buying a luxury car based on a shiny brochure, only to find the engine has a history of catching fire.
That's a great analogy. Well, it basically comes down to the mechanics of off-label use and just the incredibly lucrative nature of the aesthetic market.
Okay, so how does that work in practice?
So a device might be approved for, let's say, destroying abnormal cervical tissue. It's a legitimate medical tool. But a clinic will buy it and use it off-label for cosmetic rejuvenation.
I see. Yeah.
But we don't just see this friction with lasers and energy devices. We actually see it in biological treatments, too, like the O-shot.
Right, the orgasm shot. This is a massively popular treatment right now.
Very popular. The marketing materials we reviewed show it costs around $1,200. It's a series of 3 injections using platelet-rich plasma, or PRP.
Yeah, so for that, they draw your blood, spin it down in a centrifuge to isolate the growth factors, and inject it back into specific areas.
And they claim there is 0 downtime and that patients can experience hyperarousal within just 3 to 7 days.
Now, to be fair, the biological science of using your own blood's growth factors to stimulate tissue regeneration is undeniably promising. It's not just snake oil.
Right, and there was a study on this, wasn't there?
Yes. To test this, researchers published a randomized controlled trial in the Green Journal, which is a highly respected publication in obstetrics and gynecology.
Oh, wow. So what did they find?
The study actually proved that PRP injections into the anterior vaginal wall do improve female sexual function.
So the science works.
Yeah.
But proving that actually triggered a massive intellectual property dispute, right?
It really did. Dr. Charles Rinells, who is the physician who invented and trademarked the O-shot, pushed back aggressively against the study.
Wait, really? Why would he push back if they proved his concept works?
Because he pointed out that while the researchers proved PRP works, they didn't follow his specific trademarked protocol.
Oh, okay.
Yeah, they specifically omitted injecting the clitoris, which he argues resulted in a much smaller magnitude of improvement than his full procedure provides.
That is wild. It raises such a fascinating question about the intersection of commerce and medicine. Like, how much does a specific trademarked protocol actually matter versus just the basic underlying science of injecting PRP?
It's the central question, and it highlights a critical vulnerability in how we deliver cellular therapies today.
Which is?
Well, the basic science works, but without strict, standardized, globally agreed upon protocols, patient safety and the consistency of the results are totally up in the air.
Yeah, that makes sense.
You cannot simply inject biologically active material into complex tissue structures based on fragmented, unstandardized methods and just, hope for consistent clinical results.
Right, which ultimately leads you, the patient, caught right in the middle. So if the commercial market for these cellular therapies is this chaotic, how do regulatory bodies bring this under control?
It's a massive challenge.
Yeah. Like, how do governments ensure that biological treatments are manufactured and delivered safely to you?
Well, the UK is actually attempting to answer that exact question with a completely new legislative approach.
Right, the July 2025 MHRA legislation.
Exactly. Their Medicines and Healthcare Products Regulatory Agency introduced a world-first framework. They amended the human medicines regulations to allow for the on-site manufacturing of advanced therapies right at the point of care.
Wait, let's unpack this. Advanced therapies meaning cell and gene therapies, tissue engineering, blood products, all of that.
All of that, yes. Under the traditional model, a massive, centralized pharmaceutical factory would manufacture a complex therapy and then physically ship it to a hospital.
Right, which takes time and massive logistics.
Exactly. But this new law legally empowers hospitals, local care settings, and amazingly, even mobile units like ambulances to act as regulated manufacturing units themselves.
Think about the logistics of that for a second. Instead of a factory hundreds of miles away shipping a highly sensitive temperature-controlled drug to a hospital, the ambulance itself basically becomes a miniature manufacturing plant for your highly personalized medicine.
Yeah. The local site acts as the final manufacturing step, and they are overseen by a central control hub to ensure absolute compliance with safety protocols.
That is incredibly futuristic.
It really is. By decentralizing the manufacturing, but highly regulating the physical process through strict government oversight, healthcare systems can drastically reduce wait times for personalized biological therapies.
And I guess it avoids the Wild West dangers we saw with the commercial aesthetics market.
Exactly. It takes the promising biological science out of the unregulated commercial space and places it firmly into a strict clinical environment where safety isn't optional.
Biology is incredible for regeneration, but, sometimes the medical problem isn't cellular. Sometimes you have a physical mass that just needs to be removed.
Right, the mechanical side of things.
Yeah, and the actual hardware, cutting the tissue, is advancing just as fast as the biological treatments. The data coming out of the 2026 ESGE Congress is completely redefining what we even consider major surgery.
Let's look at robotics, for instance. There was a study from University Hospital Crosshouse in Scotland that looked at robotic-assisted same-day hysterectomies.
Oh, I remember this one.
Yeah, they achieved a 94% same-day discharge rate.
Which brings us right back to the statistic from the beginning of our deep dive. They successfully performed a same-day discharge on a patient having a massive 2.9 kilogram uterus removed.
Which is astounding.
I mean, that is the size of a 36-week pregnancy. And she went home the same day.
Another study comparing robotic myomectomy, so that's the removal of uterine fibroids, showed that the robotic approach cut hospital stays down to 1.2 days.
Compared to what?
Compared to nearly 3 days for standard laparoscopy.
So question for you. If we are sending people home the exact same day after removing a 2.9 kilogram organ, are we just discharging patients sooner and expecting them to tough it out at home? Or has the tech just become that gentle?
It's actually the latter. It is the absolute precision of the technology.
How so?
Well, standard open surgery requires large incisions through muscle and fascia, right? Which triggers a massive inflammatory response.
Makes sense. It's a huge trauma to the body.
Exactly. The body has to divert an enormous amount of metabolic energy to heal that abdominal wound. But robotic surgery minimizes that collateral damage so significantly that the systemic inflammatory cascade is actually blunted.
Wow.
Yeah, the body simply doesn't have to endure the same traumatic physical insult.
There was another technique we looked at from the Congress called V-notes.
Oh, V-notes is fascinating.
Yeah, that stands for transvaginal natural orifice transluminal endoscopic surgery. It is a completely scarless surgery performed entirely through the vagina. It's like fixing a ship's engine from the inside by pulling the parts through the exhaust port rather than cutting a massive hole in the hull of the boat. You get all the benefits of a vaginal approach, but the surgeon uses high-definition laparoscopic cameras for perfect visibility.
And the data supports it. An ongoing randomized trial out of France showed that V-notes has an approximately 83% outpatient success rate.
That's huge.
It is. And what's crucial here is that it expands who can actually get minimally invasive surgery. It is a game changer for nulliparous women.
Meaning women who haven't given birth.
Right. Or those with particularly large uteri over 280 grams, where traditional vaginal hysterectomies are often just too difficult or dangerous to attempt.
But, whenever we see ultra-advanced, high-tech procedures like this, there's always a question about the learning curve.
Sure.
If the machinery is doing the heavy lifting, what happens when a resident is at the controls instead of a seasoned attending physician?
It's a valid concern, and a study from Germany looked at exactly that. They analyzed laparoscopic hysterectomies performed by residents and fellows, and then compared them to attending physicians.
And what were the results?
Well, the residents did take 17.6% longer to complete the surgery.
Which is to be expected. They're learning.
Exactly. But there was absolutely zero increase in postoperative complication.
Wait, really?
None. Zero. The procedural structures and the visual precision of the technology are so sound that even while the surgeon is learning, patient safety is completely preserved.
Okay, so the mechanical revolution is getting you home safely and quickly. But there's another layer to this surgical revolution that demands attention.
Right.
It's not just about getting the mass out, it's about what you leave behind. Specifically, protecting your future and preserving your fertility.
Yes, and this requires us to really question our long-held surgical defaults. Let's look at ovarian cysts, specifically endometriomas. The traditional gold standard treatment has been a cystectomy, which is physically cutting the cyst out of the ovary. But a prospective randomized study showed that this physical excision drops a woman's anti-Mullerian hormone, or AMH, by 41% after 6 months.
Wow. And AMH is the primary marker for your ovarian reserve, right?
Yeah.
It indicates how many viable eggs you have left.
Exactly.
So losing 41% of that is a devastating blow to someone who wants to have children. Why does cutting out the cyst destroy the egg supply so aggressively?
It's a mechanical issue. When surgeons physically peel the fibrous cyst wall away from the delicate ovary, they inevitably strip away healthy surrounding ovarian tissue.
I see.
Yeah, and that healthy tissue contains precious egg follicles, so you are physically removing healthy eggs along with the disease.
But the researchers compare that excision to something else, right?
Yeah.
Laparoscopic ethanol sclerotherapy.
Yes. And using that method, the AMH only dropped by 26.6%. It preserves significantly more of the patient's fertility.
So how does the alcohol work compared to just taking a scalpel to it?
Instead of peeling the tissue apart, they drain the cyst and flush the inside with 96% ethanol.
Oh, wow.
The alcohol chemically destroys the active lining of the cyst, so it treats the disease without requiring the surgeon to aggressively scrape away the surrounding healthy tissue.
I have to ask, if sclerotherapy preserves your fertility that much better than cutting the cyst out, why on earth isn't it the default everywhere right now? Are we just too culturally conditioned as a medical establishment to surgically cut out a problem?
You hit the nail on the head. Institutional inertia is incredibly powerful. Surgeons are trained for years to physically excise disease.
Right.
So shifting from a surgical excision model to a chemical fertility-sparing model requires widespread retraining and, honestly, a complete paradigm shift in how we even define a successful surgery.
We see that same fertility-sparing strategy with fibroid removal too, don't we?
We do.
Yeah, the study out of Geneva on laparoscopic myomectomies focused on uterine artery occlusion, because bleeding is obviously a massive risk when removing fibroids.
Absolutely.
But by definitively occluding or temporarily blocking the uterine arteries during the surgery, surgeons dropped the average blood loss from 436 milliliters to just 138 milliliters.
That's a massive reduction.
It is. And over a 24-month follow-up, blocking those arteries had zero negative impact on AMH levels or pregnancy rates.
It's all about intervening precisely. And, the earlier we intervene, the better we can preserve long-term health. The adolescent ultrasound study in our stack of sources is absolutely vital for anyone listening who has a teenage daughter.
Let's talk about that one. Researchers did targeted ultrasounds on adolescents aged 12 to 20 who presented with severe period pain or dysmenorrhea.
Right. And by looking for very subtle anatomical markers on the ultrasound, like the fibrotic thickening of the uterosacral ligament, they found a 39.3% detection rate for pelvic endometriosis.
Nearly 40% of these young women with severe pain had a physical detectable disease.
Yes.
By finding it on an ultrasound at age 14, doctors can start medical intervention immediately.
Exactly. These young patients don't have to suffer through a decade of delayed diagnosis, constantly being told that their debilitating pain is just normal.
Right, which happens all the time.
It does. We can treat the disease medically before it ever requires massive, radical surgery down the line.
So we've covered the biological treatments, the mechanical hardware, and the preservation of fertility. The final piece of this deep dive puzzle is the digital layer.
My favorite part.
Yeah, how artificial intelligence, virtual reality, and even macro-environmental concerns are directly impacting the care you receive.
Let's start with virtual reality because this trial out of Spain beautifully highlights the mind-body connection in medicine.
Okay, set the scene for us.
They took 159 patients undergoing office hysteroscopies, which involves placing a camera inside the uterus, usually while the patient is fully awake.
Sounds incredibly uncomfortable.
It is. So half the patients used VR headsets displaying a relaxing mindfulness environment during the procedure.
And the results.
The VR group reported significantly lower pain scores on the visual analog scale. The conscious distraction actually worked.
That's amazing.
It is, but here's the catch. The researchers also tracked objective physiological stress markers, so blood pressure, heart rate, and skin conductance, which measures sweat gland activity.
Okay.
Those physical markers didn't change at all compared to the control group.
Wait, really? So the VR headset essentially tricks the conscious brain into feeling less pain, but your body's physiological alarm bells are still ringing just as loudly. That is wild.
It's fascinating. It shows that while we can digitally alter a patient's perception to improve their comfort in the room, the deep physiological trauma of the medical intervention remains entirely unchanged.
But digital tools are moving far beyond just distraction, aren't they?
Oh, absolutely. They are actively analyzing the disease now. Researchers in Italy are using machine learning algorithms to scan MRI images of deep endometriosis.
They're using something called radiomics.
Exactly. The AI analyzes pixel-level features using metric scores like Gini importance to distinguish between active inflammatory lesions and older fibrotic scar tissue.
Think of it like looking at a satellite image of a dense forest through heavy smoke.
Okay, I like this.
The human eye just sees a gray, blurry mass. But the AI can analyze the microscopic thermal data of every single pixel to tell you if the trees down there are actively burning, or if you were just looking at charred wood from a fire that burned out 5 years ago.
That is a perfect way to visualize it. The human eye simply cannot differentiate the subtle textures on an MRI, but the AI can.
Right.
And eventually, this autonomous analysis will predict exactly how a specific lesion will respond to a specific therapy before anyone even picks up a scalpel.
But, for all this digital and robotic advancement, there was one study in our stack that brought everything crashing back down to human reality.
Ah, yes. The carbon footprint study.
Yeah.
Yeah.
A discrete choice experiment surveyed 95 physicians about how they choose which surgical technique to use on a given day.
And what do they prioritize?
They ranked patient preference as the most important factor, which makes sense. But they ranked the carbon footprint of the surgery dead last.
Now, you might think doctors just don't care about climate change, but the data showed that 81% of those doctors said they are actively concerned about it.
So why don't they change their professional behavior to be more green?
When asked that exact question, 65% cited time constraints and 64% cited costs.
It's honestly heartbreaking. We have hyper-advanced robotic tools and AI prediction models, but the actual implementation of them is completely bottlenecked by the harsh realities of hospital administration.
Yep. Doctors simply do not have the time or the budget to prioritize macro-environmental concerns over the immediate pressing demands of the patient sitting in front of them in a 10-minute consultation window.
It perfectly synthesizes the landscape of modern medicine, doesn't it? We have the technology to do incredible things, but integrating it into the daily high-pressure reality of healthcare is incredibly complex.
It really is.
Which brings us to the end of our deep dive today. We've journeyed from the cautionary tales of unregulated vaginal lasers and fiercely guarded aesthetic protocols to the UK's brilliant new framework that turns local hospital beds into regulated cell therapy factories.
We've covered a lot of ground.
We really have. We've stepped into the high-tech operating rooms of 2026, where surgical robots, scarless procedures, and AI pixel scanners are completely rewriting the rules of how quickly you recover and how your fertility is preserved.
And I think we've seen that the biggest hurdles to better health aren't always technological. They are regulatory, anatomical, and, well, deeply human.
Absolutely. To everyone listening, thank you for taking the time to get well-informed with us today. It's a complex landscape out there, but understanding the mechanisms behind these treatments is the first step to making empowered choices about your own care.
I want to leave you with one final thing to ponder before we go.
Go for it.
We started by talking about that traditional, predictable, brightly lit medical clinic. But if your local hospital is actively becoming a localized manufacturing plant for your own biological cells, and robotic interventions have you recovering at home by dinner time,
Yeah.
how long until going to the hospital for surgery feels less like a major medical ordeal and more like a quick pit stop at a hyper-advanced biomechanic?
I love that. Instead of a murky, unpredictable landscape, it might just become the most precise, personalized tune-up of your life, something to explore on your own until our next deep dive.